that. This is putting a straight piece of metal on a straight line into someone's back. And it's amazing how we as residents and as medical students found it so difficult to do when all we're doing is putting a straight thing in a straight line. And it took me years to realize that everything we had to do with the setup, right? Getting the patient aligned right. And also recognizing that there's a certain number of patients that I just can't do an LP in, you know? And I don't know what it's like in your hospital, but our interventional radiologists have become our best buddies. When a 350 to 400 pound person comes in complaining of a headache that blew off the top of their head and their CT is normal, I don't even try to do the LP. I call the interventional radiologist. When I have someone who's had you know, back surgery, or who has, you know, look at that back and they're like this, and you know it's nothing but calcium all the way down. And so I went over to watch the interventional radiologists do LPs, and it's amazing. They're lying on their bellies, they're curved over a bit of a curve. Their fluoroscopy, you watch the needle go in, you can see the needle go in. It's impossible for them to miss because you watch them find the line. And they always get it first stick. And so I've stopped stressing about the difficult patients because I can get an LP from our interventional radiologist 24 hours a day for the difficult ones. And so it's made everything a lot easier. Now, we don't do enough LPs probably. We don't do enough LPs. And I think that you should take away the message that if those two letters come into your brain, if they even sort of skim across the surface of your brain, it usually means you should be doing it. And when you find yourself trying to convince yourself why you shouldn't be doing the LP, you should immediately hit yourself on the side of the head and realize that's a bad thought. You know? It's just something, if it comes across your brain, and you know you can do it. Yes, you know our policy is we get a CT, and if that's negative, we do an LP. But you know our CTs are pretty good, and if you don't want that LP, I could understand. And you could talk yourself out of it. But the thing that we have here is that we've sort of relied more and more on CT. And I want you to read that first article. It's one of the articles you should read if you haven't already read it. It's by Hall from the BMJ from January of 2005, or 2004, I'm sorry. This is an article that had nothing to do with LPs and nothing to do with subarachnoids or meningitis. So you say, well, why are we looking at it? It's because it was an article that looked at kids under the age of 18 months. And it said we radiated cephalohemangiomas on the scalp of kids with half the amount of radiation required to do a normal head CT. Half. And cognitive levels in those kids were consistently less than those who didn't get this treatment. Their high school graduation rate was less. Their cognitive function was poorer. In fact, what probably happens, their dendritic growth was stymied and slowed down. So that radiation to a child under the age of 18 months to their head is dangerous to that child and will impact on their cognitive performance in life. Now that's really important because, you know, not just for subarachnoids where we're thinking about doing LPs or for meningitis or whatever, but you have to remember for head trauma, if you look at the national guidelines that are recommended in the United States, under the age of 12 months, any hematoma on the scalp is an indication for a CT. That's one of the national recommendations. Under the age of 18 months, anything greater than a centimeter in size, a CT is recommended. And you should realize that the CT is a dangerous weapon on an infant under the age of 18 months. And so what we've done since this article came out is we've drastically changed our approach to CT in kids under the age of 18 months. I can tell you we watch a lot more kids. We CT a lot less kids. And every time it's time to think of a head trauma case or whatever for CTing infants, we think about it 5, 6 times. We talk about it. Do we really need to do it? Is this really important? Because it is going to have an impact. And the problem with CT, of course, is that all of its risks are invisible. Whereas an LP, you know, when you put the needle in, is there going to be a traumatic stick? Is it going to be problematic? Is there going to be a post-LP headache? There's these risks that you go on, but the CT, you don't know what the risks are. You can't see them, so it's simple to do. And I know Greg talked about the risk of CT in the abdomen with contrast and the risk of lifelong risk of cancer. But CT of the head in infants is something you should be worried about. So what's the downside of the LP? We've talked about this, the post-LP headache. How many of you have had an LP? Only one or two. Did you get a headache? You look like you have the physiognomy to get a post-LP headache. Seriously, skinny women get post-LP headaches. Did you? Did you get a post-LP headache? How was it? And wasn't it wonderful? Did you get a patch? And you know, we should be making sure that if we're going to do the LP that we do it right. That you try and do everything possible to avoid it. And it may be difficult to perform. The agitated patient. You know that person who comes in, febrile, altered mental status, stiff neck, who's thrashing around. How do you do the LP? You know, the whole issue about traumatic taps and whether that's a valid tap and how do I go against it. So there are downsides to both, and we need to go through this. Now, number 3 and 4, try to define in the febrile patient in whom you are considering an LP, who should you CT first? And they have a derivation set, so this is not ready for prime time. This hasn't been validated in a prospective study. This is a derivation set. Says greater than age 60, immunocompromised state, history of CNS disease, altered mental status, recent seizure, focal findings. The problem with that was 60% of their rule-out meningitis cases required a CT first. And I don't know what it's your practice, but certainly my practice is not to CT 60% of the people in whom I suspect meningitis. And I find this way too many CTs. Because there is an urban legend circulating that you have all heard. That urban legend says when you take a 25-gauge needle and put it in someone's back, their cerebral peduncles will come out through that 25-gauge needle. How many of you have heard that urban legend? Right? How many of you believe it? Answer, you all do. Because what's your first thought when you do an LP? I wonder if his pressure's raised. I wonder if he's got raised intracranial pressure. You know what? It's an urban legend. It's never been documented. Yeah. Yeah. I agree. Before there was CT in the days of the giants, I was there. I remember when I first started my residency training, we would put ultrasounds on the sides of people's heads to see if there was a midline shift. We didn't have CT. It was a wonderful thing. But you have to realize that that doesn't happen. The brain's not going to come oozing out of your needle. Okay? First off, raised intracranial pressure in and of itself doesn't cause herniation. I can tell you that there's been no documented case in the literature. There's been 6 or 7 case reports of people getting LPs with mass effect. Not just raised intracranial pressure, but mass effect. 2 of them were actually showing brainstem dysfunction because of the herniation. And were showing apneustic breathing, so they were going down the tubes. And in the case reports, both of them got better for a couple of hours after the LP. So there's never been a documented case of someone dying from an LP that went in when there was raised intracranial pressure. So it's an urban legend.
How accurate are pressure readings?
How accurate are they? If you do them properly, they're very accurate. And I could tell you, I think I was a first-year resident. When a person came in, I thought she had meningitis because she said she had this headache and a temperature of 101, and I didn't, because she was a little bit sleepy, I didn't get the history of how it came on, so I put the needle in, put the manometer on, and you know when you're adding the second part of your manometer, that you're starting to say, I'm in trouble? Because at that point, I believe the urban legend. And her pressure was 47. And nothing happened. And in fact, when you have people with pseudotumor cerebri, they come in to get their brains drained, literally. It's amazing, these people. Have you ever done this? Drained them for, right? It's amazing that these horrible headaches. In fact, this one woman who was about 250 pounds figured that I was the only guy that could do an LP on her. She would actually delay until I was on to come in to get her LP done. And she consistently did 25 to 27 cc's of fluid drained for her headache to go away. And what's amazing, she'd come in, her pressure was never less than 45. Never. And you'd put the needle in her back, and she would tell you when to stop. She'd say, my headache's gone, you can stop. Okay. So the first time I did, I said, this can't be true. Her pressure was 19. Every time after I measured her pressure was 18 to 19 when she said, okay, you can stop. And every time there's 25 to 27 cc's I'd drained off. She knew perfectly what was going on. So raised intracranial pressure is not something that you need to worry about. And in fact, and we'll go through some papers, CT can't tell you if there's raised intracranial pressure. So if you're doing a CT to see if there's something you should worry about, the CT can't tell you anyway. It could tell you a mass effect, but that doesn't tell you if there's raised intracranial pressure. There could be something there, but that doesn't mean the pressures are high.
Pressures don't determine whether you herniate necessarily. It's the mass effect.
But that's just it. But putting a needle in your back doesn't have you herniate. So doing it right, there's some articles there that I put in there. You do not need to get consent from a patient who's alert and oriented because they are agreeing to the procedure. If they have altered mental status, if they're not of the right age, you need to get consent. Local anesthesia down to the level of interspinous ligament. Yes, even in infants it should be doing that. There was studies there, number 8 and 9, which are very disconcerting to me because I really believe in pain control, and all my research and my publications have been on this. And these two studies, number 8 and 9, talk about doing infants, and LPs in infants. Neither study found that local lidocaine improved first stick rates in infants or in neonates. No effect on the traumatic tap rate. Neonates struggled less during the LP if they got lidocaine, but they struggled a lot when they got the lidocaine. So that these two studies would take away the message in terms of getting an LP done in a small child or neonate. Adding the lidocaine doesn't change anything in terms of your success rate. That gives you the message, therefore, that you shouldn't use lidocaine, and I hope you don't take that message away. You really should be, and it's important to follow. Now, the reason we talk about neonates is because, as you know in the talk that was already given about meningitis, the risk of meningitis in kids after being neonates is almost non-existent. The average age of meningitis in the population is now 25 or 26, whereas 15 years ago the average age was 4, which is why we as a group are not doing very many LPs in kids anymore because there's a lot less meningitis. That's why they get vaccinated. But if you take a look at some articles there, we talk about, and number 11 is the one you should look at along with number 10 and 11. But number 11, start with number 11. How you hold the child. Well, we all know how we hold neonates when we do LPs, right? It's the old, we hold them like this. So we grab them by the knees, we grab them by the shoulders, we bend them like a pretzel in two so the doctor can stick the needle in the back. Well, what does that do to them? It turns them blue. That's what it does. If you take a look at number 11, they did transcutaneous O2 monitoring. They looked at 3 positions for neonates. Lateral knee chest, which is the most common way we do it. Sitting or modified lateral. In the lateral knee chest position, the PO2, not the O2 sat, the PO2 was below 50 for 3 minutes on average. That's a long hypoxic period. And it can't possibly be good for that infant, for that neonate. If you were sitting less than 50 millimeters of mercury for about a minute, and it's all due to diaphragmatic compression. Number 10 said that infants, not neonates, were allowed to breathe oxygen 100% for 3 minutes prior to the LP. And there, they had O2 sat rates less than 85%. drop from 92% of their infants to only 11%. So the take-home message is if you have to do an LP in a very young kid, pre-oxygenate them, continue to oxygenate them if you can, and make darn sure you're monitoring their O2 sats. Hypoxia is not an insignificant problem in that young age group. And it's the #1 complication. And let's face it, if your procedural sedation policy in your ED, if you were told that your procedural policy had you having people with PO2s less than 50 for 3 minutes while you were reducing shoulders or whatever, how do you think you'd go and review? Don't you think Jaco might be just a little bit upset? Oh yeah, they're all at 80% O2 sats. Well, an LP is a procedure. And this is a very high risk in these kids, so you should be looking out for it. Needle selection. How many of you are using Sprott needles, the atraumatic needles? Not very many. Only a couple hands go up. You probably should be. And the way to get it right, because I know what you're going to tell me if you've tried them, is when you try to go through this skin, it's a pain in the butt. That they wiggle and they wobble, and when you try to get through the interspinous ligament, it doesn't work well. So here's a little, this is one of the reasons you come to this talk, is you take a regular needle and you put the Sprott inside it. And you go down to the interspinous ligament, then take out the bigger one and use the Sprott needle to continue.
Just got a new kid in our department that has that regular needle that's about 1.5 inches, 2 inches long, right on the spinal, as you described,
Yeah.
part of the kid.
Yeah.
So you bring that to the very tip of your spinal, and then you go in theoretically in the spinous ligament, and you advance
Yeah.
the 24 needle. It's not going to help you in a 300-pound person, because it'll only have a normal body happens.
And it really makes you able to use the Sprott needle, because the biggest problem is most people find it sort of seems like this isn't really a straight thing. It's a blunt tip and it wobbles and you can't get through the stuff. And so people don't want to try it. So it's a way that works. I'm glad to hear there's actually kits that are now coming in with it, because in fact most physicians who've gotten to use the Sprotts, that's what they do anyway. Is because the only way they could get them to go in properly. So you might want to look that up. Stick to a small needle. Numbers 12, 13, and 14 take a look at this idea of size of needle. You have to understand that if you take a 21 gauge needle, which to me seems like a cannon in someone's back, there's a 55% risk of post-LP headache. That's unacceptable. And I know you say, well, if I put a 24 or 25 in, then geez, it barely drips out, it takes forever. Gee, that's too bad. Make it happen like that. So now Article 12 said in patients with high body mass index, atraumatic needle increases the risk of multiple attempts. And that's the problem. The bigger you are, the harder it is for that atraumatic needle to get in, which is why you have to use this technique. But the risk of post-LP headache is about 50% with the atraumatic needle of what it is with a normal needle. So you're cutting in half the risk of headache with the atraumatic needle. Number 13, if using beveled needle, here's another one of those myths we were told. Remember when you were always taught how to do an LP? And they said, you know that little bump on the LP needle has to face the head so you know where you're going? That was the wrong teaching all along. You're not supposed to put the bevel towards the head. You're supposed to have the bevel throw lying on the side pointing towards the sky. Because the bevel has to be parallel to the fibers. Now, I'm just trying to think in my mind, these tiny microscopic fibers running up and down the dura, and the needle is supposed to be sliding between them rather than cutting through them. And you say, gee, that's a bunch of hokey nonsense. Well, it isn't. Because if you actually put that little bump facing skyward, you cut in half the risk of post-LP headache. So it seems like such a silly thing, and it seems like this theory of between the fibers rather than through the fibers seems like a bunch of hokey nonsense. But I don't care what the real reason is. It cuts in half your risk.
Is there any data to show in adults that whether you sit them up or do them in a matter of acute?
So the question is there any difference? The only difference is that in the vertical position compared to the horizontal position, you can't do pressures. but the success rate is better.
To get less, empirically less headaches, and maybe because I'm more successful at it, but I don't.
Well, it might be because you're more successful, but the way if you want to get around it is once you get the needle in, just have them lie on their side.
Did that with 350 pounds. Just to turn this through.
So, what about other things you can do? Number 14, use a large needle, a 20 gauge needle. Can you imagine? Had a 32% headache rate. What about this idea of keeping them lying down?
Could you do the bevel thing one more time? I think I've been doing it wrong. You have the bump, they're sitting up.
So it faces to the side.
Oh, okay.
So if they're sitting up, it doesn't face towards the head. It faces perpendicular to the head. Because you want the bevel this way, not this way. Okay? So if you're sitting up, whatever position you put it in, you don't want that little bump facing the head or the butt. You want it facing one side or the other. That's what you want. Lying down. You know, lying around's only good for a couple of things. It's a great position for sex, and it's a great position to sleep. That's about it. Okay? Lying down post-LP headache is silly. It doesn't do anything. It doesn't, what do you think? That's another myth of an LP. That's right. I went through 3 inches of body, and when I stand them up, they're going to leak. It's just going to like oil coming out of it's going to drip on the floor. If that happens, man, you must have put a needle this size in their back. It's called a spigot, and we use it to get maple syrup in Canada. But that's not how it works. And there's a great study there, number 15. This was as extreme as you can get. I have no idea how they got volunteers for this study, how they got people to sign consent for this. They said 24 hours lying down after an LP. Can you imagine? Versus getting up right away. So never mind this 2-hour crap. 24 hours lying down. The people who lay down for 20 hours had a higher post-LP headache rate. Never mind their backache and their butt ache. They had a higher post-LP headache rate if they stayed in bed for 24 hours. They had a higher overall headache rate, and they had a higher backache rate. So everything was worse by keeping them lying down. Number 16, 6 hours versus immediate, no difference in headache rate. Note, as you should, that females are more at risk for post-LP headache. So the only reason you're having them lie around, well, I'm waiting for the results. Really. And honestly, if you are that pressed for a bed, you don't even need to have them lie around. They don't need to lie around. And I remember when I used to start out that, you do the LP, you'd put that little bend in, and then you'd very gently turn them over the line. They couldn't move, and we'd take their blood pressures. We had to be so delicate. It's all garbage. And the literature is there to show you that that's true.
What if you have several sticks and blood?
If you have several sticks, it doesn't matter for lying down. It's if you get blood, you get blood, and it's inside, it's not outside.
I've heard a couple different things about the introducer, having to put it back in before you pull it out, or whether that makes a difference as well.
Yeah, the question is, what about putting the introducer back on because you're going to cut something on the way back? That's all nonsense. Oh yeah, it just sucks everything right up. No, that's... Once you're done, you're done. The whole reason you're going in the first place is just to not take tissue with you as you go through. I will tell you, yes? Okay, so the question is, unless you're worried about pseudotumor or mass effect, is there any reason in checking pressures? I'm trying to think of one. For documentation purposes? No, not really. If you're worried about meningitis or subarachnoid, it's not going to change your diagnosis. And in fact, I would bet you if you got people out of this room and took them in a corner and say, do you measure opening pressures all the time? People would go. If you ask them in a public place with a bunch of people around, they'll all do this. But no, I bet you most of us don't do it. Okay? One of the things you have to remember, and this was, I don't know if this was mentioned in the meningitis talk. If you have a valid reason to do a CT before the LP, right, in someone with suspected meningitis, but you're worried maybe there's a, an abscess there, or because I'm still worried, despite what Jim says, that the brain's going to come rushing out my needle. Don't forget that there are certain antibiotics that sterilize the CSF very quickly. And there are certain cephalosporins that can literally make your CSF sterile in under 70 minutes. I don't know about your sites, but if you do a CT in my place, we got to order the CT. That's a 20-minute delay to 30-minute delay. You get the CT. You got to wait for the radiologist to read it. You got to do your LP. By the time you do all that, and do your LP, get the fluid out, you might have sterile CSF.
You still have white blood cells.
You still have white blood cells, but you can have white blood cells from viral meningoencephalitis.
But if I'm so worried, then I'd rather take the chance to sterilize.
I understand that, but just so you understand that there is that risk. So that what you have to do then is you have to then do have to do antigen testing, and you have to do other ways of testing, so that if you realize that, geez, I got to get my steroids in, and I got to get my antibiotics in, but I'm kind of worried about his altered mental status. I really want to do a CT first. Maybe he's got an abscess or some focal findings. I want to do an abscess survey first. That's fine. But just realize, watch the clock, and if you're past an hour, you should be not doing more than just culturing to trying to pick up the identification of the bug. Okay? It's important that you remember that. So I'm not telling you to not think of certain things and not to do it, but that you're going to give the antibiotics and everything before, that you might get in a situation where your culture comes back negative because of your excellent treatment. Okay? Treatment for post-LP headaches. It's amazing what we will do to avoid doing the right thing. We give them caffeine pills. We tell them to stay in bed a couple days. We give them something like prochlorperazine or DHE, and it gets rid of their headache until they get out of the emergency department, and we tell them to give it a couple more days. When you have a post-LP headache, only one thing works. It's a blood patch. Now, I'm going to suggest a couple things. One, if you ask anybody, how does a blood patch work? The answer is, well, I don't have a clue. It's not because a blood clot is like a cork blocking the hole. Okay, that's not how it works. But we don't know how it works. Two, since we're creating the post-LP headache, I'm going to suggest to you that we should be curing the post-LP headache. How difficult is it to put a needle into someone's back and squirt blood exactly where you were the day before when it caused the headache?
Isn't it in the epidural space?
It is.
How do we know when to stop?
How did anesthetists know you were there? They inject air. You go in with a needle, you get past the spinous ligament, you inject air, you're in the epidural space. You're not through the dura, you're before it, and you inject blood. How do they do it?
They might do it a little more often than us.
They might, but it's sort of, I'm just suggesting, since we're the ones causing the problem, and it really isn't a big deal to do it, you might want to consider learning how to cure the problem. Because I know that there are certainly people in this room that have a devil of a time getting their anesthetist to come to the ED to do the blood patch. In fact, I can tell you it never happens in our emergency department. We send them to the recovery room because anesthesia won't come to our place. They just, I think our floors must be dirty or something because they just don't come to our place. But, I know there are sites, every time I talk, there are people in the room who come to me and they say they can't get the anesthetist to come. And it's a hassle, and it's an argument, and this and that, and this and that. Some of you may have great relationships. Anesthesia may come in and do them for you very quickly, which is fantastic. But you might, this is not a difficult procedure. Doing an epidural is not difficult. So the question is, are you just doing it routinely? The answer is, if you're doing the things I've suggested to you, the risk of post-LP headache is only about 5 or 6%. If you're using an atraumatic needle, it's a 25 gauge, and you're doing things, your risk is only 5 or 6%. So if we went back where we're using traumatic needles and they were 21 or 22 gauge and there was a 50% risk, I would tell you, gosh, you probably should be doing that. But since the risk is only 5 or 6% if you're doing everything right, then I would say I don't think it's worthwhile doing as a routine procedure. You might say, well, I might want to learn to do it and do it on several patients in a row just to get used to doing it. But I'm not telling you should do this. I'm just, for those of you who have difficulty with your anesthetist, to think about it, because this is not a difficult thing to do.
Well, I think my question is more, if you were to put it in at the same time as
No, I understood that.
does it hurt anything?
No. It doesn't, as far as I know, there is almost no downside to a blood patch other than the fact that you stick a needle in their back again, and therefore you increase by that factor the risk of
I
infection.
think what she's asking though is that you get the first LP, you get the CSF, pull it back a little ways, put in a little
Right.
bit of blood.
I understand what she's asking, but I don't know if there's any downside to that, and so is there any risk to the patient to just do it at that point? I don't have an answer to that. Okay? But it's something I just wanted to raise at the end for you to consider, because it is the only treatment. I've seen patients who've gotten, prochlorperazine or DHE and had their headache completely resolved and sent home, see, you're taken care of, and 2 hours later they're having their headache once again, or they get caffeine pills, and we put it off and we delay it and we delay it. I really want you to take the message that, in fact, the treatment is a blood patch. But because some of you may have difficulty, you may want to learn, but the thing most important you should be doing is doing the techniques to make sure that they don't get the post-LP headache. If you're dealing with a slender woman who is at greater risk of a post-LP headache, I think you should be advising that person that they are at greater risk, and advise them what the signs are so that they know what to do and when to come back. Because it actually is as high as 20% risk, even if everything's done right in a slender woman.
Since you mentioned it, can you describe the technique that you would use? For instance, what blood tubes would you draw for the patient? Would it be the CBC tube or the...
No, you want clotted blood. So you drop a 10 cc's of blood in a syringe, just regular syringe. You attach it. You've already found. You could take. It has to be blood that's going to clot. It can't be heparinized blood. It can't be the CBC tube.
Okay.
And you just inject 10 cc's through your needle after identifying the epidural space with some air, and you just inject 10 cc's.
Okay.
That's all you do. And in fact, what you can do, yes? Maybe. And unfortunately, there's no literature saying that should be done. But, and it's someone like yourself who's had a couple of them, if you need another LP, maybe you should be getting it done routine. But I haven't seen any literature saying that should be done. Yeah, I use an epidural catheter needle. That's what and I've done it 3 or 4 times. And if you want to just make sure you're doing it right, all you really have to do is once you find the epidural space, the anesthetist don't do it this way. I just get the nurse to draw the blood then, and then she gives me the syringe and I just inject it. I don't wait around. The anesthetist just draw it up because you want it in a syringe anyway, because otherwise you're going to suck it back out of a thing. So you just want the syringe anyway, and it just goes back in. So talk about it, think about it. You may never do it. You may have a great anesthesia department. But since we are the cause of the problem, you should at least ask yourself, should we be the cure?
Yeah, with your blood patch, how much blood do you use?
10 cc's. 10 cc's. And is there a myth? You could use 5 or 6 in some. You can use 10 in others. Is there since we have no idea how it works, there's no, well, you have to have a minimum of this or a maximum of that. There is no true, this is how much and here's why. There is, here's how much we do in our institution. Some of the anesthetists in my hospital use 5 cc's. Is it based on science? No.
This article said 23 mLs in their mean blood volume.
I know. It's all over the place. It really is all over the place. If you ask, well, okay, what study has been done to show that it should be this? It's not there. And that's why I say this is something, I'm not going to kill you, go do it, and here's how to do it. I'm telling you this is something you discuss, think about, and you may choose not to, which is fine by me. But just make sure that therefore you have a good agreement with anesthesia, okay, that they are going to respond. Last question, we'll take a break.
For bench 20
Is there literature showing that anesthesiologists are capable of doing it?
I don't care if they've got it, because they've already got that privilege, but I don't know.
Right. And again, that's why you can't do it on your own. You have to work it out as a group, that here's what we as a group are going to do, or here's what we're going to do, and talk with the hospital. Don't forget, for most credentialing things, JCAHO has set a standard. JCAHO has said that however a procedure is done, it has to be done the same way wherever it's done. So if you're going to do it the same way, that's okay, just like procedural sedation. They don't care who's doing it, as long as everybody's following the same rules.